Hi everybody, Dr. Daniel, and today I'm talking about, does transient global amnesia, TGA, relate to migraine? Syndrome of isolated episodic confusion with amnesia was described by Morris Bender in 1956, and Fisher and Adams gave the condition the name that stuck, transient global amnesia, or TGA, in their article in 1958. TGA is commonly found with migraine, and migraine's spreading wave of depolarization sweeping across the hippocampus may be the cause of the syndrome. I wrote a textbook on TGA, and to do that I reviewed the two existing textbooks on TGA, the last of which was published in 1991, plus 554 articles from the rich trough of medical literature. I reviewed the early history of amnesia and early studies in the psychiatric literature leading up to Bender's seminal article in 1955. I divide the subject into clinical, EEG, CAT scan, SPECT scan, PET scan, sonogram, and MRI papers, and then discuss the literature on associated medical conditions, review articles, and etiology, ending with a chapter on clinical workup and treatment. In total, the book is 306 pages and 10 chapters. The book is an extensive review of the subject with 554 bibliography references and 45 digital images, written especially for the clinical behavior neurologist, psychiatrist, or psychologist. It's the first modern review of the subject in 21 years, and it discusses the exciting DWI MRI findings, which have set the neurology world on fire. No recent article or text has reviewed transient global amnesia in such a detail as this book. The same painstaking and elaborate literature review style is evidenced throughout the book, placing into one compendium a body of data and references to TGA not available anywhere else. The entrance picture on this blog post shows an MRI scan which has one of the mysterious dots in the hippocampus at the end, or the arrow that occurs a day or two after the attack of TGA and then disappears. This is the mystery of the syndrome. So, does transient global amnesia, TGA, relate to migraine? The medical literature on migraine and transient global amnesia shows a positive relationship in certain cases. Transient global amnesia is one of the most mysterious clinical conditions in neurology. Occurring usually only once in middle to late age, the affected person is suddenly robbed of memory for the past, the present, and briefly the future. Repetitive questioning without learning the answers supplied marks the typical case, and frightened family members and significant others labor to bring the patient into hospital for scanning and medical evaluation. Although the cutoff time for duration is defined as 24 hours, most cases clear in 4 to 6 hours with no memory of what happened during the elapsed time, and that's called amnesia. Now, this next segment from here to further on down in line in this article are from my textbook on transient global amnesia, Cases of Migraine and Amnesia. The next series of articles are not cases of transient global amnesia, but rather cases which detail the early literature regarding migraine and amnesia. Living, neurology's supreme cataloger and savant regarding all things to do with migraine, wrote in 1873. We have next to consider the disturbance of the higher cerebral faculties, which sometimes attends the megrim paroxysm. He called migraine megrim, M-E-G-R-I-M. And this may be regarded, for the most part, as either intellectual or emotional. The former is represented in some instances by loss or impairment of memory, and by others by confused, incoherent, or tumultuous ideation, very rarely by hallucination, the latter by general depression, or vague subjective feelings of anxiety and dread. And he spoke about that as, at this period, that is, following the affectations of sight and touch, her intellect becomes confused and her memory at the same time for half an hour or so much impaired she can't even remember the name of any of the medicines she's ever taken. As the visual phenomenon passed off, his memory usually failed so much that for a time he was mentally incapacitated, and whatever he read or did during that period of time left no impression. Those are cases Living had. Living did not describe the typical benign TGA episode, but he wrote an encyclopedic monograph in which he recorded the mental symptoms that his patients had experienced during attacks. 16 out of 67 of Living's patients had confusion, trouble with memory, or disturbance of consciousness. 9 of the 67 patients had an onset of migraine before age 20, and the youngest was at age 9. After Living, confusion as part of a migraine attack was rare in the neurologic literature. Flatau, writing in 1914 in German, confronted the problem of migraine and mental symptoms. He called the problem Dämmerzustand and proposed that the term migraine equivalent not be used unless the psychosis occurs in a person who also suffers from unquestioned migraine attacks when the cessation of the hemicrania and the beginning of the psychosis approximately correspond in point of time, and when the form of the psychosis is the form most frequently encountered in migraine, that is, confusional migraine. Mersch, Mayo Clinic neurologist, writing in 1924 on psychic manifestations in migraine, said that during the clouding of consciousness, amnesia frequently occurs, and reported 2 patients with amnesia during migraine attacks. His review of the literature included Hall, writing in 1840, who noted the relationship of sick headaches, which is usually migraine, to psychic disturbances such as stupor, delirium, and unconsciousness. Living, in his excellent review of the subject, tabulated 67 cases of migraine, and 20 of these with emotional and intellectual disorder. Magazzini coined the term dysphrenia hemicrania transitoria to describe these psychic alterations and classified them as abortive, transitory, or protective. Flatau considered that migraine psychoses are an entity and not to be confused with epileptic equivalents, and his study found that the confusional states are the most commonly associated mental changes. One of Mersch's cases of memory loss follows. Case 1, a man aged 42 years old had a periodic sick headaches associated with scotomas, nausea, and vomiting since the age of 4. There's no history of migraines in the family. In July 1918, he awakened a friend by talking in a natural voice of happenings of the day before. He was lying limp in bed and could not be aroused and had no convulsions. About 20 minutes, he regained consciousness, was extremely nauseated, and for 2 or 3 days had a severe bitemporal headache. In June 1920, a similar attack occurred during the day in which he suddenly, while walking, became confused in mind. This state lasted for about 10 minutes and was followed by nausea, headache, and vomiting for the greater part of the day. In July, again in August of the same year, he had spells of similar character with a sudden lapse of memory lasting from 5 to 20 minutes and followed by nausea, headache, and vomiting. From that time up to the present, he has had several attacks in which he has even fallen but has never had convulsions. The attacks are always followed by nausea and headache and usually by vomiting. The general neurologic examinations were negative. Mersch commented, when one realizes the vagaries of migraine, there seems every reason to believe that these interparoxysmal mental changes are an index of the innate constitutional makeup. It's possible that many of the peculiarities which are ascribed to certain persons, such as occasional vague visual phenomena, mild recurring headaches, and apathy, periodic mental dullness, or other periodic mental fluctuations, are larvated forms of migraine. It's also true that the headache in a migraine attack may be replaced entirely by a visual aura, which in turn is followed by a psychic disturbance. Mersch's cases were not the typical attack described by Bender, however, with anxiety, retrograde amnesia, and repetitive questioning. Nielsen, writing in the American Journal of Psychiatry in 1930 on migraine equivalent, commented that psychic disturbances are entirely replacing the usual symptoms of an attack of migraine have led to a great deal of discussion and some controversy during the last 3 decades. And in this article, Nielsen reported a single case. The patient's a physician, age 37, who comes with no complaint except episodes of mental disturbance. These did not incapacitate him, but he's worried for years about the possible significance because genius and dementia praecox, which means early dementia, occur in the family of a paternal half-uncle, and he had consequently feared for his own mental state. Aside from the above facts, he knows of no nervous mental disturbances or of migraine in the family. The attacks of mental disturbance may be described as follows. He feels a mild emotional depression come on. Things in general seem serious. Then a feeling of strangeness supervenes, and this is followed by a peculiar confusion. During this, he is perfectly oriented, yet cannot give an orderly account of anything. He's in possession of multitude of facts concerning medicine and his environment. There are large defects in his memory, and hence organization of his knowledge is lacking. Actually, the defects are so large, it seems to him that only a small group of facts makes their unbidden appearance in his consciousness. This isolation of facts and events, he says, is the outstanding difficulty in the episode. There's no association of any kind between these groups of facts. Further, he remembers nothing during the attack for more than half a minute. He says he feels as though he sees events through a long tube or under the high power of a microscope and is unable to establish the relations between the various fields observed. He can move the tube to another field, but then has no recollection of the one just observed. This soon leads to confusion. Practically, this state has the following effect. He cannot recall events, lodge passwords, formulas, dates, names, appointments, or promises at will. They may all come to him, but he cannot commend them. It's difficult for him to carry on a conversation because he cannot recall at any moment his last statement he made. At the time he receives a reply to a question, he doesn't know what he was asked. Consequently, he cannot deal with people, cannot take a history from a patient, cannot dictate. He repeats questions and appears to others very absent-minded. He feels as though he were in unfamiliar surroundings and everything seems unreal. The unreality is the most distressing feature of the whole episode, he states. Fortunately, the disturbance lasts only from 3 to 6 hours, and the episodes appear only about once in every 6 to 12 months. After the episode, he has a perfect recollection of the events and can recall all his confusion and embarrassment. All right. Evans, writing in Brain in 1966 on transient loss of memory, an organic mental syndrome, stated that sudden loss of memory without gross evidence of clouding of consciousness is often regarded as cautiously or unconsciously motivated. But some recent reports have indicated an organic amnesia can occur without associated impairment of consciousness and can be distinguished on clinical grounds from motivated amnesia. Evans pretended 3 patients, 2 of whom gave a history of migraine, described migraine-type symptoms during the attack. They saw tachypsia, which is a visual migraine event, or one-sided headache, which occurred after a very hot bath. Evans stated, the clinical histories of these 3 patients have so much in common that it may be assumed that they are expressions of the same disease process. One of his patients was 35 years old, which is younger than the 56 to 80-year-old range offered by Fisher for Adams for patients developing TGA. Regarding causation, he said, quote, no firm conclusion can be made about the pathological basis of these episodes. In older patients, a transient ischemic episode seems the more likely, while in younger patients, epilepsy or an equivalent of migrainous hemiplegia are possible causes. He treated his patients with reassurance and advice to avoid hot baths, which sometimes sets off attack of TGA. Classic attacks of transient global amnesia. Now we're really talking about TGA. That other part was just migraine and confusion and mental troubles. Most writers credit Morris Bender with the first modern description of a spontaneous attack of transient global amnesia. In 1956, Dr. Bender wrote in the Journal of Hillside Hospital his account of a syndrome of isolated episode of confusion with amnesia. Dr. Bender described 12 patients he'd seen for a single brief period of defective memory and confusion with a complete retrograde amnesia. He noted that this particular syndrome is difficult to classify. It does not seem to fit into any of the known etiologic categories. At the end of the article, he stated, from the foregoing deliberations, an anatomic etiologic classification of the 12 patients with episodes of defective memory and subsequent amnesia cannot be made at this time with any degree of certainty. Of the various possibilities considered a transient circulatory disturbance of the brain, which would seem to be most acceptable. Thus, with these words, Dr. Bender swept into neurology and into medical awareness this unusual, fascinating, and disturbing clinical syndrome of middle to late age. The same year, 1956, as Bender's original article, Gaillota and Corjon in France wrote about l'ictus amniques in the Journal of Medicine de l'A and described the same symptoms. They did not refer to Bender's paper, but described clinical similar symptoms which they attributed to a vascular cause. These writers used the same phrase, les ictus amniques, that Bignot had first used in 1909. Then, in 1958, Fisher and Adams, writing in Transactions of the American Neurological Association, gave the syndrome its English name with the title of their article, Transient Global Amnesia. This is the name that stuck, and the extensive literature written since the 50s all call the syndrome transient global amnesia. They pointed out that the clinical manifestations were limited, for the most part, to a defective memory involving the events of the recent past and of the present, but leaving personal identification intact. Recovery appeared to be complete. Fisher and Adams claimed they described a distinct clinical syndrome which has not been clearly described in the medical literature. The attacks came suddenly and without warning, or symptoms of seizure or motor or sensory defect. So next I'm going to discuss some cases of transient global amnesia just associated with migraine. Gilbert and Benson, writing in the Journal of Nervous and Mental Disease in 1972 on transient global amnesia, report of 2 cases with definite etiologies described. 2 cases. The first with a typical attack of amnesia with repetitive questioning, right frontal throbbing headache, and remission of symptoms in a few hours. The patient had a 25-year history of paroxysmal throbbing hemicranial headache, often preceded by scintillating scotoma and associated with photophobia. He experienced a period of amnesia for a period of several hours the night of admission. Heathfield et al., writing on the syndrome of transient global amnesia in Brain in 1973, described 31 patients with amnesia suffering from etiologies including transient global amnesia, epilepsy, migraine, temporal lobe encephalitis, and psychogenic. Before the reports of Fisher and Adams, sudden attacks of loss of memory were usually regarded as being of hysterical origin, although evidence had accumulated during many years that such attacks might occur as manifestations of temporal lobe epilepsy. In fact, Jackson had said that in 1888, and also rarely during episodes of migrainous headache or as a migrainous equivalent, Mersch, 1924. In addition, the psychological origin of some attacks of loss of memory, particularly the amnesia, which invariably accompanies fugue states, had become well established. Kennedy and Neville wrote about that in 1957. Oliverius and Jensen, writing on transient global amnesia and migraine and headache in 1979, reported 5 migraine patients with TGA. Patient 2 from their series follows. A 58-year-old woman without a family history of migraine. Since the age of 25, she had suffered from unilateral throbbing headache on either side and accompanied by nausea, vomiting, photo, and phonophobia. Previously, attacks occurred on weekends for the past 3 years, every 2-3 weeks. Some years ago, she had consumed considerable amounts of ergotamine, which was Gynergen. 14 days before admission, she awakened in the morning with headache which had subsided following the administration to one of her suppository Gynergen. She has memory of the following 10 to 12 hours. Then, 15 to 20 minutes following the intake of another suppository, sudden and total amnesia occurred and continued for the following 12 hours. Her husband found her disoriented and asking the same questions repeatedly. She was initially admitted to the local hospital, was found oriented with regard to personal data, but not to time and place. She had no memory of the events that day. The following day, her behavior was normal. On our admission to our department, neurological exam was normal, blood pressure, fasting glucose was normal, EEG was normal, brain scan normal. Kaplan et al., writing in Neurology in 1981 on transient global amnesia and migraine, described 12 patients with TGA and migraine. 6 of the patients had common migraine, and 6 had classical migraine. In this article, written before the first International Cachet for Headache in 1988, after which common migraine would be called migraine without aura, and classical migraine would be called migraine with aura. 3 patients had classical migraine with either their TGA, and 9 had severe headaches with amnesia. Kaplan et al. Defined TGA as the inability to form new memories, repetitive inquiries, retrograde amnesia, initially encompassing a period of days, months, or years for the attack, but gradually shrinking after the attack, leaving permanent amnesia only for the events during the attack, and absence of other neurologic symptoms and signs. This definition eliminated consideration any patient with permanent retrograde memory loss or stroke, or TIA-type symptoms. Kaplan et al. Advanced theoretical considerations that supported the possibility that TGA might be a migrainous phenomenon. These considerations included the abrupt onset and transient nature, suggested a vascular etiology. However, patients with documented posterior circulation strokes had no preceding TGA episodes. Writers who included amnestic deficits with posterior circulation occlusive disease also had other signs and symptoms, and the memory deficits were not transient. Vertebral basilar occlusive disease is common. If TGA is a manifestation of vertebral basilar disease, it should occur more frequently. Migraine is a common vascular disturbance with an unexplained bias for posterior circulation vessels. Basilar migraine accounts for posterior circulation disease, but is very rare. The most common symptoms of classic migraine are visual and sensory. Migrainous vascular disease often causes symptoms rare in occlusive vascular disease. Positive phenomena such as scintillating scotomas, migrating paresthesia, and the gradual spread of symptoms from one sensory modality to another are all commonplace in migraine, but are uncommon features of occlusive vascular disease. TGA is basically benign if one includes only typical patients with pure transient amnestic spells unaccompanied by other phenomena and associated with repetitive queries. Migraine is also benign in contrast to exclusive posterior circulation. Kaplan et al. Pointed out that most vascular spasm can be documented by cardiologists during coronary angiography in some patients with angina pectoris. Vascular spasm occurs experimentally in the brain by putting blood in subarachnoid space and occurs clinically after subarachnoid hemorrhage. Kaplan et al. Wondered if there might be instances of vascular cerebral spasm distinct from that usually labeled as migraine. They closed, stating, vascular spasm may explain TGA in some patients not known to have migraine. In 1982, Fisher summarized 78 cases, writing in the Archives of Neurology, in an article entitled Transient Global Amnesia, Precipitating Activities and Other Observations. Regarding migraine and headache, Fisher's patients noted TGA occurred during a severe headache in 2 patients. 7 other patients had symptoms as follows. 1 recalled having migrainous scintillations earlier in the day of his spell. 2 complained of suboccipital headaches during their spells. 2 had a headache earlier on the day of the spell. 1 had a headache on the preceding day, and 1 a headache that developed after the spell had subsided. Kaplan admitted that TGA had no definite confirmatory laboratory investigations and fuzzy boundaries. His analysis provided later writers with a firm structure for defining the syndrome. Olson and Jurgensen, writing an actoneurological scandal in 1986 on Liao's spreading expression in the hippocampus, explains transient global amnesia, stated, TGA is of unknown etiology. They acknowledge that the 2 most favorable etiologic hypotheses have been a TIA in the posterior cerebral artery or epileptic discharge in the hippocampus, but they felt that neither of the 2 proposed mechanisms seemed likely. TGA is not associated with increased risk of TIA in the posterior cerebral arteries, and epilepsy is unlikely because events are not repetitive, never generalized, and because the EEG is usually normal. Olson and Jurgensen noted that spreading depression could be elicited mechanically, electrically, chemically, thermally, and by sensory stimulation in experimental animals. Spreading depression is associated with depolarization of neurons and glial cells, change in electrical chemical gradients, slow potential changes, depression of EEG activity, and increased glucose consumption and cerebral blood flow. These changes return to normal quickly, but occur in a narrow zone of brain tissue which spreads at a rate of 2 to 4 millimeters per minute. The EEG recovers within minutes, but cerebral blood flow may remain depressed for an hour or longer. Attacks of migraine are associated with changes of regional cerebral blood flow, whereby at the onset of symptoms, cerebral blood flow is reduced at the posterior pole of the hemisphere, and the reduction spreads anteriorly at a rate of 2 to 3 millimeters. The authors thought that the relationship between spreading depression and migraine was, quote, so striking that spreading depression can be regarded as the most likely explanation of the aura symptoms of classic migraine. Olson and Jorgensen stated that previous authors had noted a relationship between TGA and migraine, and they thought that, quote, theoretically, spreading depression thus seems to be a very likely pathogenetic mechanism of TGA. Topical glutamate has been known to cause spreading depression in the cortex and could possibly be liberated in the brain by emotional events. Jorgensen and Jorgensen closed with the following statement. Since the hippocampus plays a central role in human emotions, the following sequence of events could possibly explain TGA. A highly emotional experience excites the hippocampus. Neuronal activity liberates glutamate, which triggers a spreading depression, resulting in reversible functional ablation of the hippocampus. All right, articles on spreading depression, migraine, and TGA. Olson and Jorgensen, the same authors, wrote in Acta Neurological Scandinavia in 1986 on this. And then Bartsch and Duschel wrote in 2010 in Lancet Neurology on transient global amnesia, functional anatomy, and clinical implications. Now, in my blog article at drmigraine.com, I have a picture of the spreading depression. Pathophysiological mechanisms linking migraine and migraine with aura with TGA have been widely discussed, as several studies have reported a higher incidence of a history of migraine in patients with TGA than in healthy controls. However, patients rarely had active migraine the months before TGA or migrainous features during the acute TGA, indicating that an acute TGA is not a reflection of episode of acute migraine with or without aura. The occurrence of headaches during the acute episode is not associated with history of migraine. Well, off the record, I'm going to say that's what they said, but that's really not true. As you've seen the articles I've seen, there are many patients who had migraine at the time of the event of TGA. A key pathophysiologic mechanism of migraine is cortical spreading depression that mirrors a glutamate-mediated transient neuronal and glial depolarization. So Bartsch and Duschel suggested that the following pathophysiologic mechanisms may play a part in hippocampal dysfunction. Some sort of a trigger activates cellular correlates, which lead to a metabolic stress of CA1 neurons, which results in increased glutamate-mediated calcium influx, anaerobic glycolysis, increased lactate, and decreased cellular diffusion. These cellular activities cause structural MRI changes, such as the transient evolution of the diffusion lesion on MRI, reversible T2 prolongation, cytotoxic edema, and lactic peaks as a marker of anaerobic glycolysis. After this, behavioral clinical changes would be noted of acute perturbation of CA1 circuits, which leads to acute TGA, followed by rapid functional compensation in 4 to 12 hours, and then finally structural and functional restoration. Other writers along this line were Prediller and Lutz and Vincent, writing in Headache in 2000 on transient global amnesia, migraine, thalamic infarct, dihydroergotamine, and sumatriptan. Well, migraine is a vasodilatory syndrome, and sumatriptan and dihydroergotamine are vasoconstrictors. And they gave a talk discussing the fact that vasoconstriction may be related to this kind of thing of transient global amnesia. The writer stated, this observation suggests care in the use of vasoconstrictors in severe lasting migraine and the need to respect the recommended delay of 24 hours after the use of ergot derivatives before prescribing sumatriptan. They also pointed out that transient global amnesia classically occurs after cerebral or coronary angiograms. There's a lot of literature on that, even when the findings are normal, suggesting a role for vasospasm. And Donnett, writing in Headache in 2015 on transient global amnesia triggered by migraine in the French Tertiary Care Center, an 11-year retrospective analysis. She commented that the etiology of transient global amnesia is unclear and that flow disturbances in the medial temporal lobes is part of the problem, and there have been other ideas that have been looked at what caused that. She thought that TGA occurring during a migraine attack was rare. Well, really, it's not. There's a lot of that reported, as this report shows. Since a Valsalva maneuver, such as forceful vomiting, is frequently described as the origin of the attack, blocking venous return through the perivenous cava may allow brief retrograde transmission of high venous pressure from the arms to the cerebral venous system, resulting in venous ischemia to the diencephalon or mesial temporal lobes and causing TGA. Well, that was the time in 2015 there were a lot of articles written about vascular causes related to Valsalva, which later hadn't really panned out. Minju et al., writing on an article in Neuropsychiatry Clinical Neuroscience in 2019 on strong association between migraine and transient global amnesia, a national inpatient sample analysis. They wanted to explore variables and comorbidities associated with transient global amnesia. They used a nationally representative database, and they found that patients with migraine were 5.98 times more likely to have a diagnosis of TGA care paired with patients without migraine. Then I'm going to quote some from a Mayo Clinic Family Health book, 5th edition, which is online. And they have a lot of interesting things to say about migraine and transient global amnesia. Transient global amnesia is identified by its main symptom, which is inability to form new memories and to recall the recent past. Once that symptom is confirmed, ruling out possible causes of amnesia is important. So they said that there should be a sudden onset of memory, verified by a witness. There should be retention of personal identity despite memory loss. There should be normal cognition, such as ability to recognize and name familiar objects and follow simple directions. There should be absence of signs indicating damage to a particular part of the brain, such as limb paralysis, involuntary movement, or impaired word recognition. Additional symptoms and history that may help diagnosis of TGA are duration of no more than 24 hours and generally shorter, gradually return of memory, no recent head injury, no evidence of seizures during the period of amnesia, no history of active epilepsy. Along with these signs and symptoms, a common feature of transient global amnesia includes repetitive questioning, usually the same question. For example, what am I doing here? Why did we get here? So these patients to see a medical doctor, they say, and they comment on events that have been associated as possible triggers of TGA, which have been sudden immersion in cold or hot water, strenuous physical activity, sexual intercourse, medical procedures such as angiography, endoscopy, mild head trauma, acute emotional distress as may be provoked by bad news, conflict, or overwork, risk factors. Interesting, high blood pressure and high cholesterol, which are closely related to stroke, are not risk factors for transient global amnesia, because transient global amnesia doesn't represent blood vessel disease of aging, and your sex doesn't seem to affect the risk either. The clearest risk factors are age. People age 50 and older have a higher risk of TGA than do younger people. History of migraines. If you have migraines, your risk of TGA is significantly higher than if someone without migraine. Complications. TGA has no direct complication. It's not a risk factor for stroke or epilepsy. It's possible to have a second episode, but extremely rare to have more than two. But even temporary memory loss can cause emotional distress. If you need reassurance, ask your doctor to go over the results of your neurologic exam diagnostic tests with you. Prevention. Because the cause of TGA is unknown, the rate of occurrence is low, there's no real way to prevent the condition. And that was all by the Mayo Clinic staff. Then Ken Morris et al. Wrote in JAMA on neurologic factors associated with risk of recurrent transient global amnesia. And their key points was that there was a higher prevalence of both personal and family history of migraine compared with isolated cases. In summary, After years of literature and article development since Bender's seminal article in 1966, there is a large body of information linking TGA and migraine, and this review testifies to that fact.